I was way up here.
All right, good morning. We'll go ahead and call the executive committee meeting to order, and we will proceed with the agenda as stated. The first item on the agenda today is a personal appearance by Dr. James Hughes.
He said, Dr. Hughes.
And once he comes in, Mr. President, if I could give a short introduction, I believe it'll move things along with Dr. Hughes.
Okay.
Dr. Hughes. Hey, I'm Paul Morris. I'm with the attorney. Hey, folks, I'm going to talk about 30 seconds and then they're going to hear directly.
Good morning, members of the Executive Committee. So I'll say Dr. Hughes has been practicing here for many years. His license was last renewed in 2022 and expired in 2023. So Dr. Hughes is seeking reinstatement of his license. The information available to licensure shows that Dr. Hughes has not regularly practiced clinically since 2012. The executive director denied his reinstatement application because Dr. Hughes needs to comply with Rule 1.3, which requires either passing a clinical skills assessment or participating in a board-approved reentry program. Dr. Hughes is here to appeal.
Thank you and good morning.
Good morning.
I deeply appreciate your letting me visit with you this morning. I apologize for subjecting you to this, but I did fail after 40-something years of continual licensure in the state of Mississippi to renew when we moved in 2053. Thereupon, when I sought for reinstatement, and started this process, which I appreciate, then I found that one of the considerations was the CMEs. And in 53, I went for 2.5 days to Albuquerque, expecting to get 14 CMEs. And I had a poster there, scientific poster, considering an aspect of research we'd been doing. And so I did go, I attended all the things, but when I came to get the considerations of the CMEs, I found that they had not been approved by the governing organization, but nobody ever told me from that perspective. So then I came back and now I have over 50 CMEs for the consideration for you today. I understand how you adjudicated the last consideration, and it looks like that I don't practice, but I would like to share with you that the research I do and the considerations before me in that way probably take 4 or 5 hours a week. The rest of the time is in clinical relationship with patients. You say, well, where are the source of your patients? Well, after 30 years of practice at the university, many of those that I operated on and followed through on have continued in my life as desiring to have me share with them some clinical expertise. So though I did retire from surgery in 2012, I did not retire from the aspect of taking care of patients in a general orthopedic way. So this occurs through the orientation of telemedicine. In orthopedics, it's easy to do telemedicine because you simply do a face view of the patient, record their gait, look at their range of motion, et cetera, visit with them, take a clinical history of what's going on with them, and then make a decision as to whether they need a prescription for PT, OT, or whatever, or maybe just an orthotic for their legs to straighten them out. So it's wonderfully able to do that. The second aspect is just house calls. In Jackson, it's easy to move around to go visit people. If they call you, recent one, the person couldn't get out of bed and wanted to be looked at to see if what they could do for their spine. So anyway, we adjudicated a course of action for that, and it worked out okay. The other aspect is just phone calls that they would give me themselves as to, what do I do about this, doc? What about this? How do I go from there? So obviously much I can work up, on the outside, but then if it comes time to needing a surgical decision, we refer them to somebody in town. That's one aspect of the source of patients. The second aspect is nationally, with the brothers and sisters in the Lord. I get many calls about, what do I do now? What is this? What's going on here? They'll send me photographs and I'll look at them and evaluate them and visit with them. Many of them are their children because they're concerned about, do this child need surgery or not? And so you look at that and visit with them and consider what needs to be there. The third aspect is a bit unusual, and that is internationally. I've had the privilege of, for 40 years, teaching in Russia and the Ukraine, and have made many, many contacts in that aspect. Many of the Ukrainian doctors now that some have trained with us, will call and consider, what about this war situation? What about this war wound? So you share with them from that perspective, from my Vietnam year, as well as from West Jackson, with all the gunshot wounds there. This brings us into a very personal consideration. Many Americans are over in that area. And what has happened over the years is that I get calls for health care. And that has resulted in I can give you illustrations of all these, but this one is particularly interesting because this person called up and said, I've been diagnosed with ovarian fallopian carcinoma. So it was a privilege for us to bring her over here. And I might add that in our last two houses that Virginia and I have had privilege of, one remodeling, one building, we've had a room of that's available for the consideration of handicapped people. So when we brought this one over, she stayed with us for a year and received her chemotherapy as well as her surgery at UMMC. So that's an example. The many total joints have come out of England and Germany, as well as Russia, to be taken care of here, evaluated as a physician as to what they need. And if they needed surgery, then we were able to put them in the right place for the right physicians to take care of them. So many of these considerations have to do with second opinions, particularly in spine surgery. And there are incidences in which people have been prevented from having unnecessary surgery, I'll put it that way. So in that sense, I deeply appreciate your considering the compassionate aspect of what a physician is, as well as the technical considerations. There are many times during the weeks, that there's a, hey, doc, what about this rash? What about this? What about that? One young woman was presented by her mother, and turned out, she said, what about this rash? Turned out, in looking at her, that she was hyperthyroid. So we were able to place her in the right place. So it's the compassionate care of people, and I desire, and that's the reason I would like to continue my license to carry out that which I do is in my heart as a compassionate physician, to take care of people. So I respectfully request that I be reinstated in the proper way. And with that, I'll take any questions, and thank you very much. I appreciate it.
Thank you. Dr. Lippincott, do you have any questions?
Good morning. Morning, Dr. Hughes.
Good morning.
I'm Ken Lippincott. I'm a psychiatrist from Tupelo.
Sure.
And have you, how how do you keep records on any of these
Absolutely.
people? What kind of charts do you keep?
Well, in the charts, I keep them on the electronic base. Yeah, in my computer, because much of it comes through the computer as regards to, what I do and what I say to them. And I have a narcotics license that's active and good, but I very rarely use that. And if I do, I write it down in a special chart by my desk.
Do you charge for any of the?
No.
Do you charge for?
No,
any of
sir.
the, Do you know the definition of the practice of medicine?
Taking care of people in a proper way.
I don't, I'm not sure. I guess my question is, do you need a license for the things that you're doing? And I'm not sure about that. I think we need to get some consultation with the attorney, but it sounds like since have you been doing the things that you do since your license expired a couple of years ago?
Just 1 year ago. Yeah, I mean, no, I don't write prescriptions because I don't have a license. But the license gives me the ability to write prescriptions for the physical therapy, occupational therapy, get x-rays outside. So, that's just a technical side of what I need to do to make a diagnosis and execute a treatment pattern.
So you're looking for an unrestricted medical license.
Yes, sir.
It's tough when we have these rules, that we don't have any documentation of your practice these last 12 years, apparently.
Well, I understand that consideration, but I've been doing the same thing since 2012, up to when I made a mistake and I did not renew the license, which was not intentional by any means. But I had no problems whatsoever in the care of since leaving the surgical aspect. And the license that I didn't renew was unrestricted. And there was no problems with that. My perspective, for the patient's perspective.
Okay.
Only do what I can do.
Okay. I don't have any further questions right now, Madam President.
All right. I do have a couple of follow-up questions. So, you answered the question about record keeping. How much time would you say in, say, for example, a week, do you spend not with the informal conversations, just curbside consults, if you will, but that actually involves like patient care, either via telehealth where you're actually performing evaluations or providing referrals?
Probably 30 hours, maybe 20 to 30 hours.
So it is almost like
Yes.
almost full-time, but not quite.
Yes, ma'am. Yeah, I'm always available. But then you ask about if anybody enters that availability, that's my answer was 20 to 30 hours.
Okay. And I also saw, just to kind of get a little bit about your background. So you did a really thorough job of talking about your orthopedic career. There's also some information in the packet that we were provided that speaks to your medical directorship and research work. And you said something about research and what you perform. Can you tell us a little bit about that? Are you still currently serving as medical director, and what type of research are you involved in?
Thank you. The answer is yes to the medical directorship. Number Two, it has to do with the acoustical evaluation of sounds from the body. So we are looking at the stethoscopes that have a particular algorithm within them that are digitalized and also have AI in them. So we're looking for carotid evaluations in order to ascertain whether we can determine, whether it's 20 to 30%, 40 or 50% blockage. And then you would be able to put that on your iPhone and not necessarily have to go through, the ultrasound study. So it's a preventative and diagnostic at the same time. And we're working with Valdosta Medical Center in Georgia, South Georgia, and then in Tyler, Texas, the one there. So we've got maybe 300 cases at the moment to evaluate. Then we're also listening to Swallow and whether we can ascertain whether somebody with a stroke we listen to the Swallow in such a manner that we can AI it to say, okay, you can have water or honey or whatever. So that's going on in that regard. So anyway, then the other consideration is a mice study that we're doing in Jackson for Alzheimer's. We found that 40 hertz, putting in 40 hertz continually to the mice, as well as some light sound flickering, can alter the course of the Alzheimer's and in the mice. So in that one, I can't give you any real report, but one indication that you're influencing cells is that the mice that were losing weight with Alzheimer's are no longer doing so. But that's all I can say, how we influence. The other one is the digital analog research with the nurses at UNMC as to which they prefer and what digital stethoscope they prefer. So those are just areas that keep me academically and intellectually focused.
Absolutely. Thank you for that. And then I guess the next thing is, so the initial application was denied. I understand that you're here today. Would you be willing, or would you consider, in the event that you were not able to move forward with an administrative approval for you to have your license granted, would you be willing to consider a program that would provide you an opportunity just to do clinical work or to be eased back into clinical work in a process that was reviewed by this board and approved by this board, to be able to just demonstrate to us exactly what it is that you're doing and that you're okay to do that in order to receive your unrestricted license? Is that something that you are unwilling to do, or is that something that you would be willing to consider?
Look, do I want to do it? No. Do I feel it's necessary? No. For what I do? No. But if that's what it took, then, are there any restrictions for being out? I mean, being out a year, from my functioning license, is that I lost it all in a year?
So I think that the issue is just when we look at, and I understand your question, it's actually a good question, so the renewal process, once that renewal has lapsed, or once your license has lapsed, then you kind of revert back to the rules in order to have it reinstated once you've gotten beyond your period. There's a grace period for renewal, et cetera. Once you get beyond that, then if it's lapsed long enough or been inactive long enough, then if you've not been involved or engaged in clinical practice in some time,
Sure.
and I think the difficulty is that your clinical practice, for the clinical practice that we are aware of, that you, that the board knows that you were trained and practicing under as an orthopedic surgeon, it would appear that you have not consistently seen, we don't have any evidence that you've kind of consistently been engaged in clinical care. You've explained to us kind of what you've been doing, but we don't really have any documentation that supports that you've been actively engaged in clinical care enough that it would meet the requirements. And that's kind of why we're having this conversation, why we're
Sure.
here today. And so I think I just was interested in kind of understanding what your position was, if that was something that you were against or averse to altogether. Like, I'm absolutely not doing that, because it sounds like you still have a deep love for medicine and that you care a lot for people, and you seem to be a resource and an assistant to a lot of people all over the world. And it seems to be something that's a big part of your life. And so I was just trying to understand
Sure.
if this issue was enough for you to say, you know what, if I don't do this, then I'm just going to step away and not do these things. Because it sounds to me like this is something very much that you would still like to pursue, even if it doesn't happen in this way. I just
Yeah,
wanted to know if that, I don't want to make that assumption. I just wanted to know if that
Sure,
was the
no,
case.
thank you so much for your kindness and asking the questions in a proper way. I appreciate it. I want to keep going. Okay, so that's it. I feel like I'm able, I'm capable, I'm intellectually wrapped around what I do. You know, I'm not going to treat somebody's hypertension, that's for sure, or diabetic. I'll talk to my daughter, who is the gerontologist. But, you know, as far as me personally taking care of people, yes, I would like to keep going.
Okay. I failed to mention, we have one other member. Usually there are three of us seated here. The other member of our executive committee is joining us via Zoom, Dr. Joyner. Dr. Joyner, are you still there?
Yes, I am.
Okay.
Good morning.
Good morning. So this is Dr. Joyner. He is our current secretary. He's our secretary from afar this morning, but he's been listening. Dr. Joyner, do you have any questions at all?
Yeah. What about what you're doing now is going to change if you get your license back?
Well, I can write prescriptions for therapeutic realities for the patients, and now I'm limited. I mean, I can't not really legally able to write a prescription for PT or OT or orthotics or any acute Medrol dose pack that may be needed, any inflammatories, any gabapentin for people with neurological pain. I can't write them because I don't have a license. I have a narcotic license that's active, but that doesn't, I think, cover what I want to do on a practical daily basis.
Okay. And you're not going to return to surgery?
No, sir. Nope. 40 years of night work is enough.
I agree. I'll return it to you, Madam President.
I do feet because I can shave corns off of feet for people.
Dr. Cleveland.
Thank you, Dr. Hughes. My name's Ken Cleveland. I'm the executive director.
Sure, Ken.
So, I wanted to make sure that we were all on the same page when you answered Dr. Owen's question, 20 to 30 hours a week. That's in direct patient care.
Right.
Where you're doing a history and a physical, making an assessment, a diagnosis.
Correct.
Okay. So how many patients a week is that you're seeing?
Probably about 20.
Okay. So you didn't realize for over a year and a half that you were no longer licensed in the state of Mississippi. Why did it take so long?
Until I was reminded I didn't have one. I think the board did it or something. I don't know. I can't give you the exact moment that, I just when I missed it in 53, then in 54, I found that I didn't have a license. So.
And just for our record, I think you mean 23 and 24. 2023
I had
and
I
2024.
had a license in middle of 23.
Yeah.
Right. Yes, sir.
So you last renewed in 22, which carried you through June 30th of 23.
Correct.
You haven't been licensed since then.
Yeah, that's when
But you've continued to see up to 20 patients a week.
Yeah, but I wasn't writing prescriptions. I just took care of them. In other words, you give them advice to go see this one or that one. Yeah. I didn't misuse my consideration. I didn't write prescriptions.
So my understanding of the events that led to you discovering that you were no longer licensed is that you did write a prescription for somebody, and when they went to the drugstore to try to
Right,
fill
that's
it,
correct. That's,
they got turned down.
yeah, that's correct.
Okay.
That's,
Do you remember what that prescription was for?
it was for, Jackson State Chinese student for, in Clinton for, I think he had a severe upper respiratory infection.
So it was antibiotics.
Yes, sir.
When the licensing officer asked you what you intended to do, if you got your license back, you responded, write prescriptions for family and friends.
That and the patients I see, yes, sir.
Well, you didn't include that in your answer,
Oh,
though,
I'm
did you?
sorry.
Yeah, okay. And just for your own knowledge, your DEA number is not valid without a active
Right,
state license. So you've stated
So I haven't
several
used it.
times that you have a narcotics.
but I
Well-
haven't used it.
Okay. I just wanted to make sure you
Yeah,
understand.
yeah,
that
oh, yes, sir.
The DEA would be very upset with you if you did try to
No, I
use it
understand
without an
that, and
active
and
state
that's exactly the
license.
reason I haven't used it.
So you knew you didn't have a license then.
Sir,
So you're saying that's the reason
I
you
just
didn't?
don't use the DEA, and I'm glad for the information, but I don't use it often at all.
Okay. All right. Thank you.
All right, anything further from the executive committee members?
Excuse me, Dr. Hughes, where do you see these patients?
Either on the telemedicine side of looking at it, when we dial in on Zoom, or the consideration of just talking to them on the phone, or physically, if they come to the house, or I go to the house.
And how do these patients come to you? Are these people you already know, or do you get new referrals, or how does that work?
90% of them, the ones I know, and then they'll refer, I'll get a call from somebody, say, this person suggested I call you concerning this matter.
And you did an investigator come to visit you?
No,
No. Okay, you just applied for the license. So we haven't checked to verify that you have charts and records. But to clarify what Dr. Owens was asking you, would you be willing to participate in a reentry program, which will probably require a review of your records, monitoring, and possibly some other things, but would you be willing to do that?
yeah, whatever. Most of the electronics, I can show on my iPhone or the computer, sure.
Okay, and these past, let's see, since you retired you retired in 2012, right?
Yes, sir.
And in the intervening years, up until 10 years, until 22, when you renewed your license, I think, does the renewal application inquire about how many hours a week you're practicing? Do you recall?
I think whatever the electronic data was necessary, I filled it out.
Okay, but you've been working, what, 20 or 30 hours a week these past 12, 14 years?
Yeah, yes, sir.
Okay. And do you prescribe controlled substances?
Rarely.
I was-
The answer is that, yeah, in answer to Dr. Cleveland's consideration, but rarely, and if I do, it's only a 5 or 10 to get through an acute phase to go be seen, somebody for epidural or whatever.
But the reason the the way that you discovered your license had expired was a prescription for an antibiotic was declined.
Yeah, yes, sir.
Interesting. Okay. I don't have any further questions right now. Thank you.
Madam President.
Madam President, I
Yes,
have,
Dr. Joyner.
I have one more, question. I'm a little confused about the question of whether an investigator came to your house. Did any of the investigators from the Board of Licensure come to your house or come to you to look at your records and such?
No, sir.
Sit down with you and ask you questions. And B, did any investigators from any other entity come to you?
No, sir. No, sir.
Okay,
Mr.
you.
Barnes.
Yes, ma'am. I just wanted to briefly speak to Dr. Lippincott's question earlier about whether this was the practice of medicine. I believe he's referring to candidly some infamous language at the end of the statute, which says you're practicing medicine after having received or with the intent of receiving, therefore, either directly or indirectly, any bonus, gift, profit, or compensation. And in my opinion, that is not limited to tangible compensation, such as, for example, the goodwill of a business is in fact an asset that can be a value figure can be put to it. If not, I think you can see the dangerous precedent of saying that you could do all these things without a license. For example, someone who is wealthy and who refuses paycheck, refuses check, nonetheless gets benefit in goodwill, etc. Otherwise, such a person could simply say, I'm not practicing medicine because I'm not getting money directly for it, and you have no jurisdiction over it. So there are no definitive cases that I'm aware of, but in my opinion, it can include more than just tangible compensation. On the other hand, obviously, Dr. Hughes is here ready and willing to work with the board. I just wanted to try to answer your question. That is my opinion, my personal opinion.
Just a closing comment. When the man that helps me in the cutting of the grass fell out of his tree stand, he broke his ankle. He had no place to go. So he stayed with us until he got well. And the other doctor operated on him. So anyway, again, I appreciate your listening and thanking you. And I thank you for the privilege of being here.
Thank you so much. At this time, I'll entertain a motion.
I move that the board enter into executive session. I move to close the meeting to consider whether to enter into executive session on this matter.
Is there a
I'll
second?
second.
All right, all in favor?
Aye.
Aye. All righty. So we are closing the meeting. Give us just a moment. We're waiting on Dr. Lippincott to come back with us. Okay, we are now back in open session, and Dr. Joyner, our secretary, will give the decision of the executive committee.
Get off mute. Thank you. The decision of the executive committee is that this request for licensure be denied. Thank you.
Can you read the complete decision, the full decision, Dr. Joyner?
Hang on one second. I
Uh,
got too many devices.
No, it's fine, because I think Dr. Cleveland is prepared to read it if it's a little easier. I think he has it on hand.
Yeah, Dr. Cleveland, could you do that?
Okay.
Dr. Hughes, so the executive committee has denied your request for reinstatement. If you would like to reapply or re-request from the executive committee, there's a couple of things that they would like you to perform prior to that. One would be a neuropsych exam for just to make sure that your mental fitness is there to practice medicine. The second would be recommended a CPEP course for clinical competency. So it's two different things. And then after you've completed those two different things and you have reports from those two things, then you can ask the executive committee to reconsider your request.
No, yes, sir.
So Dr. Hughes, thank you so much for coming down. It was a pleasure meeting you. One of the things that we get to do in these roles is meet physicians from all over the state of Mississippi. And you clearly have a good heart, a great heart for patients. And so we look forward to seeing you back soon.
Okay, would you make the appointment for my neuropsych, or I do it, or where do I go?
So
Would that come in the report?
So we have a list of people and places that perform these kind of things.
Sure.
And if you'll get in touch with us next week after we get through these board meetings, then we'll be more than happy to provide you with that.
Okay, and who do I contact next week?
You can either me or Paul Barnes, either one will be fine.
Okay, all right. You have a card? Something.
I will get you one.
Well, thanks, everybody. I appreciate it.
So I think you've been in touch with people in the licensing division. So if you already have Anna's number, you could also contact her and she can help you get in touch with either one of us.
Just call the switch. Ask. We'll put you in touch. She is the one who handles
What's your last name, Paul?
Barnes.
Barnes. Okay.
And my assistant is going to get a card if you wait just a second.
Sure. I just wait right after.
Yes, sir.
Thank you, Paul.
Yes,
Appreciate it.
nice to meet you.
All right, we're going to move on with the next item on our agenda, which is appearance by Dr. Clifton Scott and Dr. Josh Griffin.
All right. Good morning. Can everybody hear me okay on the Zoom?
Yes, we can hear you.
Okay, great. All right. Well, first of all, Madam President and board members, thank y'all for giving us some time on your agenda to talk about what we're requesting here. And also thanks for letting us do this via Zoom. It definitely helps us out with our schedules. I guess I'll start out and maybe give you guys an overview of kind of where we are and what we're doing and why we're interested in helping out with Miss Davis and her clinic. We've been doing hormone therapy at our Revive clinic and in my urology practice. I've been doing that for over 5 years now. I've been in Oxford for 7 years. And Dr. Clifton Scott is in Columbus, and he's also director and collaborator in our office in Starkville. And with, as we all know, the awareness of hormone imbalance in men and women has definitely become much more of a known condition, and there are a lot of people seeking treatment. And one of the things I learned early on in my practice as a urologist, seeing a lot of men and women, is that there is a lot of wrong ways to do it. And early on, we knew that we wanted to make sure that things were kind of done the proper way in order to ensure safety for our patients. And as time has gone on, we've had more requests for other nurse practitioners who are in other communities who are interested in kind of taking on that concept, and we've been happy to provide our expertise and training and ensuring that things are done safely. We really kind of see this as a medical advisory type role, and we are very hands-on with oversight and guidance and ensuring safety. And I feel like as to that end, we're hopefully upholding the standards of the Mississippi Board of Medical Licensure by making sure our patients in Mississippi are taken well care of. Unfortunately, as you all know, that there is there's still shortages of providers in our state, and there's certainly, when you look in terms of hormone therapy and some of the things that we do at the Revive Clinic, even more, a lot of physicians are just not very comfortable managing that aspect of care. And so I really feel like we kind of fit that role, and we're hopeful that we can find a way to work together here. And this has never come up until we were approached about the clinic here in Madison, and we're hoping that we could figure out if we could meet exclusion criteria for the rule that allows us to provide care beyond that 75-mile radius. Happy to take questions. Dr. Scott, do you have any comments that you would like to add to that? Or I know that you guys probably have some questions for us.
I'm sorry, I don't have anything to add at this time. Like, I guess see what kind of questions we get.
So just to start out, Dr. Griffin, I was in looking over the documentation that was provided in the letter that was submitted to the board in November. It specifically mentions, providing care or I guess training and outreach better than what can be done in the local area. So to your knowledge, what exactly is the current state of what's available in the area? Is this is this service available in this area already? And I guess I just kind of wanted to get a little bit more of an understanding of like what was meant by that particular rationale.
Sure, absolutely. And so there are a lot of these hormone replacement therapy clinics where, you know, there's most of them are done in the form of injections. And so I know that those are in the area, and there's a lot of those in particular for, you know, our approach. We do use injectables. However, we've really found really good results using the subcutaneous pellets, which are the bioidenticals that are tend to be longer lasting, so you can have more of a prolonged therapeutic effect. That's what we've had really good results with at our clinics here, and we feel the safety is as safe, if not more safe, in terms of you know, the treatment itself. In terms of other clinics in the Madison area doing pellets, there may be some in the area. That being said, I can't really speak to how many. Some of these providers that will use pellets are kind of using a national company that will, you know, provide education and support, but there's nobody locally hands-on that's really kind of there to be available for like immediate questions. Now, while there are probably directors under those clinics, from what I've understood and heard, a lot of times that's accessibility and getting responses and getting that kind of support they need is not always there. And so that's really where we feel like we can fill the gap for that, even if we are further down the road. We've always been available for our providers. Our clinics that are working under our supervision. So does that help answer a little bit? I can't speak exactly to how many clinics are in the Madison area. I know that there are injection clinics, but that's not really what we're trying to do here. We're more approaching it from a subcutaneous pellet insertion standpoint.
I think you actually
Okay.
gave me a thorough response to the
Okay.
question covered. So first it was about just access in general, number one, and then you basically preempted my second question, which was going to
Okay.
be what differences existed between you and what was there, if there was something there. So that was great.
Okay.
And I guess the next thing is, so what exactly is your relationship or experience with the nurse practitioner, Miss Davis, that you are going to be collaborating with? Is this someone who's trained in your facility or has collaborated with you some other way in the past? Like how exactly is your connection come to be?
Sure. So as of where we are right now, we've actually have not gone through with the training portion. And I would definitely preface all this to say that all of this should be predicated on her being shown to be, you know, competent. And so we have not gone, she's done the online training portion. But what we require and expect is two things. First is we have them come to our locations, either in Starkville or Oxford or both, and have exposure in our clinic to, you know, probably the equivalent of 4 or 5 days in our office to make sure they can see these procedures being performed under our supervision. And then once we kind of feel that there's that competency there, we will let her start assisting with those in our office. Moving next steps, and this is what we've done in the other offices, is once we've reached that point, when she feels ready and we feel comfortable enough, we will then go to her site and proctor her first 10 procedures to ensure that she's meeting, you know, that she's able to get under her wings there in the office. That's how we've done that in several of our surrounding communities. I don't see it being anything other than a little bit further drive down the road to make these things happen. And then we also have a lot of built-in protocols that we've kind of developed. And a lot of that's based on my experience in treating men and women and, you know, doing continuing medical education. And it kind of provides them a lot of really good, healthy guidelines to make sure that, you know, these things are being done the safe way. Does that help answer that question?
Yeah, absolutely.
Okay.
At this time, I'll see if there are any other questions from any of the executive committee members.
I have a question.
Dr. Joyner?
You're over, about 200 miles away. I don't know whether exactly it is. Who came to you first? Did you go to the nurse first, or did she come to you first for coverage?
No,
How did it start?
Ms. Davis actually came to us through a mutual acquaintance. She's been, I think in general, it's been difficult for her to find a collaborating physician that would go these extra steps and sort of allow her to be able to offer the procedures that she wants to be able to do within her clinic. So she came to us for that.
Okay, so she came to you first.
Yes.
Do we have any evidence that she's tried to contact individuals in this area? Because there's plenty of OBGYNs and such around central Mississippi.
I mean, I can't speak on that. I know that I've been approached by other, nurse practitioners, and, I think there is a lack of physicians that are willing to take on the extra liability that comes on with a clinic like this, and taking on another nurse practitioner or provider when you're not in the clinic every day. I think Josh and I or Dr. Griffin and I do a fairly good job of staying in touch with our nurse practitioners, even when we're away from the clinic. So I mean, we're pretty comfortable doing it.
Okay.
And Miss Davis is joining us today as well. And so, I mean, if that's something that will be helpful, we can certainly open that up for discussion if she's got anything to add in regards to that question. The one thing I would say, Dr. Joyner, is there's both men and women that we manage. And so you were exactly right. There's a lot of OBGYNs, obviously, who are very competent and capable of helping with some of the female aspect of it. For me as a urologist, I'm comfortable with both, but I particularly worry about how comfortable some people are with the male component of the hormone therapy.
I understand. Yeah, the rules are out there. The rules of the Board of Licensure are written so that the public and everybody can see them. And like I said, we're kind of stretching the rules where we are stretching the rules when you reach almost 200 miles away.
I think I'm actually 140 miles, so I don't know if that changes things or not.
It doesn't really change by my book. But I have great concerns about not adhering to the rules as they're written. So I mean that would be my main concern. The central Mississippi is the home of medicine in the state of Mississippi. So it just seems to me like you ought to be able to find someone here closer that adheres to the rules. Ms. Davis, do you have any comments on that?
Yes, sir. I've actually contacted Dr. John Baton. He's a urogynecologist. I tried to get him to collaborate with me to do some of the hormones. And I've contacted a vascular surgeon, but she wasn't, she has no experience with any hormones, and just different doctors or physicians in the area. I've tried to contact different doctors that I've worked with in the past, but a lot of them, I've worked in surgery and I've worked in critical care. So I haven't really had a lot of experience with doctors that really have their own clinic doing the type of things that I would like to do here. So I have reached out to other surgeons and doctors in the area, but none that kind of fit exactly what I'm looking to do here.
What is Dr. Bateman's specialty?
So Dr. Baton, he was an OBGYN, but now he does urogynecology. And he's in Flowood.
So, Tom, do you have any additional questions?
No, ma'am.
All right. I have a couple since Ms. Davis is kind of talking. Ms. Davis, can you just give us a little bit about your background and training in general, and I guess that'll be a good place to start.
So I've been a nurse for about 8 years. And I worked in critical care, I worked in surgery, I worked in recovery. I just recently got done with NP school in May, so I'm still pretty new. And I think that is the big thing of just finding collaborators that I can depend on, being able to pick up the phone and ask questions. And I have good relationships with them and their other providers in their clinic. And I feel like having that community to back me up, even if it's just a phone call, I've already felt like I've had that with just a couple of their practitioners in their clinic overall. So that's been great for me.
And you're trained as a family nurse practitioner?
Yes, ma'am.
So what exactly is your experience in hormone replacement therapy and hormone therapy in general?
So this is all new to me. And I think that with these two physicians, I feel like they could give me the best training and just hands-on experience. Like they were saying earlier, there are different companies that I could get trained through. But they are just those large corporations and companies that I don't really have the, hey, can you help me in this? Or, hey, I have a question. It's okay, well, we need to set up a phone call next week and maybe I can answer your question there. I feel like with these two physicians, they will be available for me with any questions or just really the training process. I feel like I will benefit from them much more than I could going through like a larger company. Even though they do provide that training, I feel more confident with somebody that I can reach out to that I already have that personal relationship and professional relationship with.
And so also, I noticed in the information that was submitted in the collaborative agreement, it also mentions sexual wellness, including PRP injections, hair restorations, O shot, P shots. Are so it's your intention, because we've been specifically talking about hormone replacement therapy, but there are some other things that are included here. Is it your intention, or and I guess this might be a better question since it's in the documentation that's submitted. It may be a better question for Drs. Griffin and Dr. Scott. Is it your intention to train her in these procedures?
Those would be more long-term goals. Certainly the PRP injections, when we talk about that, I'm very reluctant. Even in my practice, I've been very careful about that because I do think there's a lot of there's still lack of data on a lot of that stuff. So those are things that, as I think as we learn more and we try to further, expand on services that we offer with our program, then absolutely it might be something. In terms of the hair growth, those are usually, topical treatments. I can say in our clinics, we've not done any type of hair loss surgery or anything like that. Although PRP has been looked at, it's not something we've really taken on a lot of because, again, we want to make sure that we're ready for that. So I think those are mentioned in there is just to try to show the big picture. But, in reality, what we've done in the other clinics, I mean, primarily what's been done has been the hormone therapy part of it.
Right.
Clifton, Dr. Scott, you got any thing you want to add to that? Clarify?
No, I think with the hair stuff, we mainly work with compounding companies or something like that for,
Right.
lotions and shampoos and, to help with the hormone replacement.
And there's
Right.
overlap with sexual medicine, sexual health, hormone therapy. A lot of that comes from the hormone therapy. There are some additional things that I have done in my practice, but we don't have I'm not kind of feeding that out to all these clinics saying, hey, try this, try that. I mean, it's more of the things that we know are effective, the medical treatment, which a lot of nurse practitioners already can do, whether it's prescribing Cialis or Viagra or whatever. So they'll get more tools with time, but I mean, really, that's more of a delayed long-term
Right.
possibility.
No, go ahead. Sorry.
no, Madam President, go ahead.
You can go ahead because I was actually gonna make another comment on that, but go ahead.
Oh, yes, ma'am. I was going to say that, when you get into the hormone replacement, that oftentimes all the sexual health and sexual wellness questions come up within the clinic. And so, us being able to address those with Miss Davis as she has those patients in the clinic is something that would be beneficial for her.
Mhm.
I appreciate that. I just, in the interest of completeness, wanted to be able to this is your opportunity to kind of give clarity to some of these questions. And I think those were things that stuck out to me, especially with the PRP injections. And so, Dr. Griffin, I appreciate your candor. And I think you touched on some of the very things that I was concerned about when I saw it, because those are things that I would have thought would have definitely been reserved primarily for someone of your skill and expertise. And so it just seemed a little bit more advanced than what I was.
Absolutely. We've PRP has been used for some aesthetics and some other, there's some other indications that are used for it. I've been very reluctant to start there's a lot of that out there. And again, we try to find that balance between some of these new things that are regenerative, but we also have to remain in the confines of practicing good medicine. So personally, I have had a little bit of experience with that, going through some training, but I've not let any other providers even step into that. None of the nurse practitioners have done it, and I don't really want to do that right now. If it comes down to wording or whatever, with you guys making a decision, that's something that if it kind of adds to a little bit of confusion there, we could strike that out of the statement, because. And I guess if that ever did come up, we would want to Ms. Davis would have to apply for a competency through the Mississippi Board of Nursing too, which again, I'd be very reluctant to do at this point.
Got it. And how much of your practice is weight management?
Gosh, what?
Me, yeah.
Are you asking me, us, or are you asking Ms.
In
Davis?
general, it was just included.
Sure.
So I just want to know how much you were anticipating.
We have not really been aggressive with weight loss treatment at all, especially I know that there's been some back and forth with the Board of Medicine, the Board of Pharmacy. We've pretty much just stayed out of it. I do know now with some changes, it may open up some doors, but in reality, I would say if you looked at our practices right now, I would say less than 5% would be involved with any type of medical weight loss. Wouldn't you agree with that, Dr. Scott? I mean, it's just not really a big part of what we've been doing.
Yeah, it's not.
All right.
It's not a big function.
Thank you, Madam President. Either Dr. Griffin or Dr. Scott, you mentioned, in fact, I think it was Dr. Griffin, you mentioned that you have had great success in hormone replacement therapy by using the pellets, correct?
Yes.
Would you agree with me that pellet placement, it would be at least considered a minor surgical procedure?
I would agree. definitely it's it is a minor procedure. It takes 5 minutes, but certainly you do puncture the skin. So, I mean, I would agree 100%. It is a minor procedure.
So once we can agree on that, we can agree that there can be complications to that, correct?
Yes.
And including in that complication is bleeding. I'm just,
Yes.
what I'm getting at is from 165 miles away, how are you going to help Miss Davis if she gets into a situation where there's uncontrolled bleeding from this procedure?
Sure. Well, I think the first thing is being available and being notified. I mean, I can speak to my experience and doing this over 5 years. I've not had anybody have to go to the emergency room for post-procedure bleeding from subcutaneous pellets. I think the most important thing is the proper training. We've talked through that scenario because it would be not feasible for us to drive all the way over there. I mean, we would be certainly willing to, but that's not in the best interest of the patient. We had mentioned that, there could be some, working relationship, I think maybe with some general surgeons that Miss Davis has worked with before that might be willing to, if it came down to it, could see the patient. Again, you can't say that's never going to happen. It's extremely rare, but I do acknowledge that's one thing that we do have to we do have to consider that. Typically these things are, when we have people that come back after a pellet procedure, it's usually there could be a little bleeding and the dressing came off, or it could be just some fluid drainage from the anesthetic that we use. What we've typically done here is just hold pressure and put more dressing on there. Granted, I know you guys can't make decisions based on our experience of 5 years, but I do feel like that's something that we can have a protocol in place to help manage that.
I
And I
think
do know that after 5 years of being in the emergency room, I've yet to see any, bleeding from pellets come in, and there's, we have quite a few providers in the Columbus area that are doing pellets. So I think a lot of these complications must be being handled inside the clinics.
Oh, I think they probably are. And my concern is that we have a mid-level provider doing a surgical procedure.
Well, I understand that concern. I guess the only thing I would mention is that there's mid-level providers doing these procedures, all over the state, and they may not have as much ability or accessibility to someone on the phone as we can provide, and being able at least to have that conversation and give guidance. I do think that speaks for something. So, that's all I can say to that. But I do acknowledge the concern, and by definition, it being a minor procedure in the office.
Dr. Lippincott, any questions?
Thank you, Madam President. I'm Ken Lippincott from Tupelo. I just had a couple of questions. Ms. Davis, are you self-employed? Are you employed by a clinic or what?
So my boss, I'm a 1099 employee, so kind of, but I do have my boss is Teresa Graham. So I do have a boss, but I am a 1099 employee. If that kind of helps. I guess I am semi-self-employed technically, but I do have a boss or a manager that actually pays me.
Okay, thank you. And
Yes, sir. Yes, sir.
Who are your collaborating? What are your collaborating positions at this time?
So I have his name is John Hontzis. He's an anesthesiologist at St. D. I've worked with him for years. So that's who I have currently. He just, he doesn't do any of the hormones or anything like that. So.
Okay, thank you, Ms. Davis. and Dr. Scott and Dr. Griffin, um, um, y'all are, from what I gather from your documentation, y'all both have your own practices in Oxford and Starkville, correct?
Yes, sir.
And y'all, I know, and I noticed that y'all collaborate with several nurse practitioners, and thank you for doing that. But is this is just like a kind of an independent collaboration with Ms. Davis that you're proposing? Is that correct?
Yes, I believe. So we're
Yeah.
only offering to collaborate with Miss Davis at this time? Is that what
Yes.
you're?
Yeah, and
Yes, sir.
Dr. Griffin, Dr. Griffin, you would be the primary collaborator, and Dr. Scott, you would be the backup. Is that correct?
Either way, I could be the primary or he could be the backup. It's, what we're trying to do is make it easily, Dr. Griffin and I work well together. I mean, just already being partners. And so we're just trying to make it easy for Miss Davis to have a primary and a backup.
Okay, and I'm a psychiatrist. I don't know anything about hormone therapy, but could you tell me a little bit about what kind of male and female hormone therapy y'all are talking about?
Sure. So in men, primarily we're, almost solely looking at testosterone. In females, it's a combination, of estrogen, depending on if they're if they're menopausal or postmenopausal. And then there are very, very low doses of testosterone. Again, when you get into this, it's kind of an off-label thing, but it's being done and it's shown to be safe. Of course, we have to go by our guidelines and do our lab work and follow up. So those are kind of the main elements of what we're talking about here. We do use some oral progesterone in women as well for the protective component of the uterus. Hopefully that answers your question. And I would like to add that, my thing is, one of the reasons I got into this is I've seen countless men who would go to a clinic who would be 25 years old, who would not need to be on testosterone therapy, but were told they did. And they would go and they would get a shot every week. And I would see them when they're infertile, 6 months or a year later, and they were never told that. And, I think that was a wake up for me that, there's a lot of things not being done correctly. And we have to have the right education and we got to do things the right way. And so we do offer other forms of hormone therapy. I even offer, we even really try to empower lifestyle, diet, losing weight, whether it's with medical weight loss or encouraging through, being more active. But this is going to be a problem that just continues to be more and more prevalent, not only because we're aware of it now and we're getting blasted with social media, but also just because I think our lifestyle and our diet is really bad in this state, but many other states. So it's a national issue. And we want to make sure we're trying to do it the right way and give people options. And there are people we tell they don't need hormone therapy. They just need to lose weight or they need to get better sleep or manage their diet. And certainly these people these guys in their 20s that come in, like we're very, very skeptical. And that's all built into my protocols on trying to do things the right way without doing harm. And I think that's the bottom line, really, of why we're here.
Thank you, Dr. Griffin.
Yes, sir.
That's all the questions I have.
All right. Anything further from any of the executive committee members? Hearing none, I'll entertain a motion.
Move to close the meeting to consider.
Turn on your mic, please.
I move to close the meeting to consider whether to enter into executive session on this matter.
Second.
So it's been moved and seconded that we close the meeting to consider whether to enter into executive session. All in favor? Aye. All right, thank you. Dr. Joyner, our secretary, will give the decision of the executive committee.
Thank you, Madam President. The Executive Committee of the State Medical Board met in executive session, and their decision was to deny this request. Any questions can be referred to Dr. Ken Cleveland, the Executive Director. Thank you.
All right.
Next week.
Yeah. So I don't see them on, are they still on Zoom? Okay.
I'm
Dr.
on.
Griffin, thanks so much
Yeah.
for your appearance today. Any follow-up questions can be directed to the executive director. But it was good to see you keep doing good work out there. Say hey to Meredith and the kids. Maybe I'll see
Will
you at
do.
the pool.
Absolutely.
All right.
Absolutely.
Bye-bye.
All right.
All right, going on to the last item of our agenda is a appearance. I had my word find in there. Appearance by Melissa Sinopoli, who's a PA.
Madam President, if I could just give a brief introduction, I think it will move things along.
Okay.
Ms. Sinopoli is a PA who has not practiced in some years clinically. Her license, I believe, expired in 2018. She's applied for reinstatement. The executive director recommended a reentry program similar to those that the board has approved for physicians to allow her to reenter clinical practice. And so the return to practice plan that's in the materials was developed with the cooperation of Ms. Sinopoli and the director. And it is intended to be a shorter version of the clinical requirements for a new graduate PA and how they would be eased into clinical practice. Thank you.
Thank you, Mr. Barnes. Ms. Sinopoli, are you there?
Yes, ma'am.
All right, fantastic. So can you just tell the executive committee a little bit about your request?
Yes, ma'am. I was a GI physician assistant for 15 years until 2018 here in Ocean Springs, Mississippi. At that time, I decided to just stop working for a bit for some family requirements. Unfortunately, then COVID came and my children were out of school. And so that extended the period of time. And I was also waiting for my non-compete clause to expire. Always wanted to return back into the GI world. An opportunity came up this summer. We are lacking some providers here on the coast for GI, and I was approached and asked if I would be willing to come back to work. I'd always had the intention in doing so. I think there's just been some confusion with the PA licensure here in Mississippi. I have maintained my primary license in Florida all of these years. And we are governed by a national accreditation called NCCPA, in which we have to do our board exams every 6 years, which I've completed. Every 2 years, in order to remain certified, you have to have 100 CME credits, 50 of which are Category 1 AMA. And I've maintained my accreditation throughout my time of clinical unemployment, and then also still had my license in Florida. The problem for me was that my license, when I stopped working with my provider, whom I had been working for 15 years, I relinquished my license because even if you look on the website now, in order to have a license for PAs in Mississippi, it asks for a supervising physician. There's no option initially to request an inactive license. When I was first licensed, it was in 2003 here in Mississippi. The procedure was incredibly different than it is now. I mean, we were on paper. I had to come to the board. And when I relinquished my license in 2018, I wasn't given the option of maintaining an inactive license, during which time, for the past 5 years, I've looked online and it's not clear as to whether or not you can apply for an inactive license. So I just assumed as long as I maintain my accreditation through NCCPA, that whenever I decided to come back to work, that would be sufficient, because in no state in the US, you are unable to get a PA license without NCCPA certification. And so I have tried since August of this year to be reinstated. I was initially told that I would have to have the clinical assessment and go through a PACE program or CPAP program, which I did. I contacted all of the contacts that you have listed, and very few actually do them for PAs. I found 2 at the time, because this just doesn't seem to be an issue that we've had to face. I did pay and reach out to UC PACE. I was told back it was September 27th that they would be able to complete my assessment by the end of October. So I paid, and then they created an assessment plan, which really was just a psychological evaluation. I was supposed to have a Zoom meeting and have like 3 cases presented, and then I would have to fly there to provide in-person history and physical, which I was willing to do. I guess what happened, we were entering holiday season, and they couldn't get me on the books. And I'm certain at that point, they're having to request physicians to take time off to come in for an evaluation for me. And certainly everyone is pressed at the end of the year for patient care. So at that point, I halted that and received some information regarding from Mississippi Medical Board that they would be willing to allow me to have some supervised clinical hours. So at this point, the job I'm applying for is also back in GI, and which I've had 15 years of experience. So I'm coming and presenting here today. And Dr. Rinker is my supervising physician that is also here on the call for new position I'm inquiring about.
Okay, thank you so much. Any questions from the executive committee?
Good morning, Ms. Sinopoli.
Good
My
morning.
name's Ken Lippincott. I'm a psychiatrist up in Tupelo. And so you have have you discussed this with the people here at the medical board about this program to reentry? You've agreed for this program for reentry to practice?
Yes, sir.
Yeah, and so what is your specific request this morning?
I didn't personally have a request. I was told I needed to present myself before the board.
Okay, thank you. Thank you. We have a proposed reentry practice plan that requires board approval. So thank you. Thank you very much.
Thank you.
Dr. Joyner, any questions?
No, I don't.
Dr. Cleveland?
I would just say that, I don't know if it's Sinopoli or Sinopoli. I've been pronouncing it Sinopoli, but it doesn't matter. And I wrote this reentry plan. And so I think it covers all the bases to provide for safe patient care. And so from an executive director's standpoint, I would recommend that the executive committee allow this.
So just for clarification, how do you pronounce your name?
Sinopoli. It's not too far off.
Oh, we're just trying to figure out who was putting the emphasis on the wrong syllable. Okay.
None of us had it right.
All right. So at this time, with no further questions or comments, is there a motion?
I make a motion. we approve the proposed reentry practice plan.
Is there a second?
Second.
All in favor?
Aye.
Aye. All right. So
Thank you very much.
thank you. So that was the last appearance. Communications from the executive director.
Well, and I'll repeat this to the full board, but the legislative session has begun and it's very active this year. We feel like we have a lot of momentum going into the legislative session to get our version of the updated Medical Practice Act passed. Probably more confidence than we've ever had in years before. We've done a lot of groundwork, met with a lot of people. And as Dr. Owens knows, but the rest of y'all do not know, we met with a group called Cicero yesterday that is promoting licensure for foreign trained physicians. So.
All right. Thank you. Well, we look forward with bated breath to hear your report at the beginning of our full board meeting. Are all hearts and minds at peace at this point? If so, we will adjourn our executive committee meeting. We are a couple of minutes over for the convening of the full board, so we will give everybody about 5 to, why don't we just say 7.5 minutes to go to the bathroom, and we will reconvene at 10 after 10 to start with our full board agenda. Thank you.